And I'm delighted to have Professor Stephen Turner, consultant paediatrician at NHS Grampian and president of the Royal College of Paediatrics and Child Health. It's a bit of a mouthful. Steve has been a consultant paediatrician in Aberdeen since 2003 and became the RCPCH president in March 2024. Delighted to have him join us and looking forward to hearing your perspective, Steve. Over to you.
Neem, good afternoon, everybody. Thank you for joining. Next slide, please. So I like to end and start on the same note. Hopefully this way some of what I say is retained. So what I'm wanting to get across briefly is that if we are going to affect change, we need to work across silos. I'm here speaking for the health profession, but education, transport, law, they're all important. As it says on the right, it takes a village to raise a child. And Marcella sort of did this for me beautifully. We need to care for the whole child. We don't need to try and squeeze the child into a box. Children shouldn't be squeezed into boxes. Let's care for the child. Let's care for the individual. Let's not signpost them and let's not presume. And I think Neem has already said it again. You know, children are 25% of the population at the moment. But as far as my maths goes, they are 100% of the population in about another 70 years' time. So if we don't invest in them, if we don't look after them, we are doing ourselves a disservice. Next slide, please. So, as a healthcare professional, I would like to be unemployed. I would like all children to be healthy and well, and for me not to be needed as a doctor. However, that's not the case. The reason why children come to see me with illnesses are mostly these days determined by their environment. So if you look at the bottom of this journey, you've got a fetus, and the fetus starts off and it meanders on its way through life as it grows. And on that course, its health and well-being, physical and mental, are influenced by the lived environment. It's what the child eats, drinks, the air they breathe, and it's their space that they live in. The transport infrastructure is important to them. They need to have space to move. They need to be encouraged to be active, but equally they don't need diesel fumes going in through their front window. Law and order are an important part of this, because when society is happy and healthy and well, law and order is generally maintained. And without including law and order on this journey, the picture isn't full. But as neutral as it can be, I think the biggest bit on this journey is the bit in the red box. And it's set in the community, and it's a hybrid of health and education, because I don't think you can really disentangle those two. And it's about prevention, vaccination, early detection, particularly mental health, and education. This is about lifestyle, social norms. And if as a society we get all of these right, kids are fine, they're healthy. However, we haven't got this right, and children are physically, mentally not well, and they come see healthcare professionals. What am I going to do about that journey? And that's why I think it's really important that I recognise that it's everybody's problem, and the NHS is where the problems end up coming to in the end, but the solutions lie further and earlier along the journey. Next slide, please. So, what are we going to do? Well, I think the solutions are very well described. If you look at these documents on the right side of this, 1976 was the court report. This said, 1976, before they had mobile phones, before they had even computers. Do you remember those days? Most of you won't. The common themes back in 1976 in terms of improving child health were community-based care, putting the care around the child, not wrapping the child around the system, focusing on prevention and addressing deprivation. And these four themes have been maintained for the last 49 years. So it's well described what we need to do. But what we're going to do about it. Next slide, please. Well, from the healthcare professional, there are many things that we can do. And this is a little bit of a jigsaw. It's meant to be busy because it's meant to get over the picture. There's an awful lot that clinicians, doctors, nurses, health visitors can do to improve child health. Let me just talk about one. SDM is senior decision maker. It's getting somebody who's experienced, involved in the child's journey early on. Next slide, please. So if you involve senior decision makers in NHS 24. During the pandemic, there were many experienced paediatricians who'd either recently retired or who were shielding, and instead, in terms of getting involved, they made themselves available to NHS 24. So when a senior decision maker was involved in a call from a parent, 69% of the calls were sorted out once and for all by that senior decision maker. And 92% of those carers and parents felt that their problem was fully resolved. And it's not surprising that if you compare these experienced senior decision makers to non-clinicians working off a sheet of paper, those non-clinicians, 43% of those calls they're able to sort out straight off. And the minority felt that they were the problem was solved. The next bit is in Glasgow, the fine city of Glasgow. All referrals on the emergency basis go to an experienced clinician. 30% of admissions, 30% of admissions are averted. They're stopped without any follow-up. That's reassurance, watchful waiting, and see what happens. And the third one is a similar thing in terms of outpatients, where I'm about to go in another 40, 50 minutes. We have a system here in Aberdeen where I live and work, where we have a consultant who looks at outpatient referrals. These are children who are referred with a non-urgent but nonetheless worrying thing for them and their parents. We can sort out an awful lot more of these problems with early communication over the phone or even a letter. And what this does is it frees up space in clinic, so our waiting times drop. So if you get a senior decision maker involved early on, the pathway is a lot smoother for the child, for their family, and for the health system. Next slide, please. But a clinician can only do so much. And the purpose of this slide is to demonstrate that my zone of influence is the little green, my zone of confidence is the blue, it's the yellow spot in the middle. So when I'm going to clinic later on this afternoon, I can work out what medicines, what tests, what advice I might give parents. That's absolutely my sphere. But what I can't influence is how patients and the families travel to the hospital, whether they take their medicine, if they can get hold of their medicine, and I can influence that green area, but I might not be able to impact it. But there are other people in the community who aren't able to influence my yellow area, because that's my area, but they might be able to change the green area. And the point that I'm getting across is that we all have areas of control, and because they don't all overlap, we can work together. So what I can't do is I can't get data linkage. I can't see what the children I'm seeing in clinic this afternoon, what their school attendance is like. I can't see what the police involvement in the family have been recently. I cannot because I've tried, get funding streams to pay for people who work in hospitals to work in the community, or vice versa. And what I can't do is to get a public message across to help parents understand when they worry, when to worry, and when not. So collectively, as a community of people invested in child health, we can do it. Individually, we can't. Next slide, please. And for those of you in the crowd who are getting a sense of deja vu, that's because you've already seen this one. What I hope I've done in the last few minutes is explain why we need to work across silos. There was an opportunities mission meeting in Leeds yesterday where all of the sectors were involved, and it was great to see, because we all need to work together to do this. Hugh mentioned the word bolder and braver. This is the time to do it. We have to care for the whole child and be mindful that what we do now will improve child health now, but also improve the health and well-being of that cohort of children as they move through into adulthood and become tomorrow's leaders, tomorrow's webinar attendees, taxpayers, and parents. And on that bombshell, I will finish. Thank you very much.
Steve, thank you very, very much. Lots of food for thought there, particularly taken back by your honesty around, as a clinician, there's only so much you can do, and the need to have, I love the point where it takes a village to bring up a child, point in your chat. The other thing which I was taken back, Steve, was your reference back to 1976. Far as back as a fond year for me, but as far as back as that, in terms of, if we know the answers, I mean, why? History is a wonderful thing, right? Some people choose to ignore it, some people learn from it and try to do something better going forward. why are we still talking about the same things? Why haven't we moved on?
Yeah, that's a great question, and we've only got 25 minutes left to talk about it. I joke. I think part of it is the inherent reluctance of humans as a species to change their behaviour. So I think that the way that the parents present to primary care or to the emergency department has changed. Hasn't changed that much. I think what clinicians do when they meet patients hasn't changed. People still say, well, this is how I was taught to do things. Both as parents, this is how I was when I was a child. This is what my mum would have done when I was ill. For myself, this is what I was taught when I was ill. And people just tend to keep on doing the same thing without realizing there's a better way of doing it. So I think there is an inherent inertia in humans that has helped, that hasn't helped. I think also in the healthcare profession, when I started out, not quite as far back as 76, but it was a while ago, the senior doctor and senior nurse were in charge of the hospital. And there was a very strong clinical leadership in the NHS then. And for understandable reason, that clinical leadership was handed over to non-clinical management. And there was that need for management and a business savviness to be involved. But I think those reins were handed over too much. And we've got non-clinicians in a management position who are asked to make clinically based decisions. And that strikes me as absurd. And I think that clinicians need to be empowered to make the best decisions for their patients and for their service without needing to go to management to say, what should I do? Because invariably, there's more and more stuff being fed upstream to management who've got less and less time, and to be fair, less risk appetite and less clinical exposure to make those decisions. And everything just groans to a halt. Everybody says, well, we're waiting for management to sort it out. Oh, come on. Clinicians, pick up the ball and run with it, because if we don't, nobody else will.
Brilliant, Stephen. And as you said before, we can talk about this for a very long time. But I think the key point you make there is, we need to change. We need to have the will and need to change the way we work in order to deliver on those needs of the children. And actually, going back to what Maya Sola was saying earlier on, listening and understanding the need from a child's perspective may be different from a service perspective, and how do you close that gap?